I kind of get lost in the answer. The question I really wanted to know is 4 milligrams of Ativan in a person who's accustomed to using benzodiazepines, you wouldn't expect that to cause cessation of respiration, would you?
Not typically, even though anything can happen, not typically.
Okay.
But we always use it under monitored setting with oxygen on board.
Well, Ativan's frequently used in an unmonitored setting, isn't it?
IV?
What's that?
Vague? Does he mean in the hospital? Or?
Well, I think you have to go into the particular source of administration, whether it's by mouth or by IV. Sustained on that ground. Re-ask it.
Ativan is taken orally, isn't it?
It's administered in many ways. It can be taken orally. It can be administered by IV.
And your first preference would be to try and use it orally, wouldn't it?
Let me clarify. My preference would depend on the indication. I don't typically use Ativan or any other sedatives or narcotics to treat insomnia. There are other drugs available. But I do use Ativan for procedures. Yes.
One of the indications for Ativan is insomnia, though, isn't it?
That's correct.
Okay. Now, nothing further at this time, Your Honor.
Mr. Flanagan, thank you. A redirect examination, Mr. Walgren.
Thank you.
Thank you.
Dr. Nguyen, you have specific privileges at UCLA to utilize propofol when appropriate?
Yes, I do.
Okay. But you use an anesthesiologist when you do it?
Yes, I do.
Okay. And this is for what type of procedure?
Typical procedures that we use with propofol is direct current cardioversion, meaning if patients have an abnormal heart rhythm, such as atrial fibrillation, we would like to reset the heart back to normal sinus rhythm, and the patient has or has not failed some drug treatments. One way to do this, to use a current to shock the patient and bring the heart back to reset the heart rhythm back to normal sinus.
And when you do that, so you would be present?
Absolutely.
The
Many people are present.
Who would be present as far as medical personnel?
At least a cardiologist attending, at least an anesthesiology attending, and resident or fellow, at least a nurse. So at least 3 people.
Okay. And in this type of situation where propofol is being administered, this would be in the hospital setting?
Always in the hospital setting, and it's just not any hospital bed or room, only in the ICU or the procedure room. So it is not anywhere in the hospital. It is designated place with designated personnel and equipment available. By equipment, I mean a crash cart should be available. Why did we need personnel such as anesthesiologists, even though I could administer propofol? That's because in case that we overshoot the threshold of tolerance by the lungs, because unlike Ativan, propofol certainly could cause severe respiratory collapse and cardiovascular collapse, and there was no way to know what is the tolerance threshold to achieve the desired effect versus the threshold that the lungs or the heart could take. If we exceed this toxicity threshold while we still have not reached the desired effect, then we are in pretty bad shape. That's why we need anesthesia. That's why anesthesia is involved, and there's always a crash cart inside the room.
And what does a crash cart have?
The crash cart typically has ACLS drugs, similar to the drugs that EMS arrived on a scene when a patient was collapsing, and they could administer epinephrine and things like that. It's all within the crash cart. It has a defibrillator Actually, we already had the defibrillator out, ready to run.
Okay.
Yeah,
And in the setting, you would have all the monitoring?
absolutely.
Heart
absolutely.
monitor,
Yes,
capnography, pulse oximetry?
yes,
Okay.
Yes.
You'd have all the emergency airway equipment?
yes.
Okay. And you had indicated when Mr. Flanagan was asking you about lorazepam and flumazenil, you indicated what you really should be doing at that point is proceeding to the next level and ventilating with the endotracheal tube, correct?
Yes,
Okay. And of course, in a house setting, if you didn't have an endotracheal tube, that's not an option, correct?
in the hospital setting, especially in the CCU, that's a mandatory equipment. We never would be in the situation of not having it.
Okay. So you would not oversee or personally administer propofol without having the equipment I've listed off, including the emergency airway equipment?
No, sir.
That's a double
That's a
negative.
correct statement, what I said?
That's a correct statement, what you said.
Okay. And regarding the balloon pump, you indicated one of the reasons you proceeded with the balloon pump was to give Dr. Murray the benefit of the doubt, and by that you meant benefit of the doubt that he in fact had felt a pulse. Is that right?
That's correct.
Okay. And when you said that in these types of procedures anything can happen, what did you mean by that? You were talking about over-sedation with Ativan, or when Mr. Flanagan was talking about flumazenil, and when you were referencing the endotracheal tube, you said you need to be prepared for that because anything can happen. What did you mean by that?
For sure. I can explain. When we think of using a sedative or a narcotic, we think of our desired effect to achieve, but before that, we always have to think of what is the worst case scenario. So we have to always prepare for the worst case scenario before we even give the drug.
Okay.
Whatever the indication is, be it for a procedure, be it for insomnia, before even giving the drug to the patient, we prepare for the worst scenario. What is the worst scenario? Propofol could cause severe lung collapse, respiratory collapse, breathing collapse, and it could cause cardiovascular collapse. And propofol does not have an antidote. So we had to prepare for the worst before we even administered it. And that's why we took great care in getting all the personnel, all the equipment ready inside the room, in the proper room, before we even start administering it.
Okay, so you're prepared for any consequences?
Yes, it is a must.
Okay, thank you. Nothing further, Your Honor.
Mr. Walgren, thank you. Mr. Flanagan, recross, please.
In your familiarity with propofol,
Could you define familiarity?
well, you're knowledgeable in the drug and you've used it personally, haven't you?
I have used it with assistance from the anesthesiologist.
So you've never used it just on your own.
Never.
But whenever you've used it, it's always been in association with a procedure. Is that correct?
That's correct.
Okay. Now, propofol is used for drugs other than when a procedure is being used, correct?
Possibly.
When you're talking about a procedure, you're talking about shocking somebody, cutting them open, or doing some kind of manipulation of their body that could be painful. Is that correct?
Could be painful. One nice aspect of propofol is it induces total amnesia. So because we would not want a patient to remember how painful it is when the current passed through their body, through their heart, we wouldn't really want them to remember about that incident when they wake up. So propofol does produce that nice amnesia effect.
And when you're talking about using propofol in conjunction with a procedure, would that be then referred to as procedural sedation?
Yes, it can be.
Okay. Are you familiar with a term called conscious sedation?
Yes.
And that's different than procedural sedation, isn't it?
Sedation for a procedure, that's all what it meant. It does not mean the level. So conscious sedation versus general anesthesia versus MAC and things like that, rather than just say procedural sedation, we wouldn't still know what sedation level it is, because there are many kinds of procedures which requires different kind of levels of sedation.
Okay. Now, when you're using propofol for procedural sedation, it means there's a procedure that's being used for, correct?
Yes.
And the recommendation is that the person doing the procedure shouldn't be in charge of the propofol.
No,
Is that
I disagree with your statement.
so? The person doing the procedure can also be in charge of the propofol?
Let me clarify, because I am not sure I understand your question.
Well, if you were shocking somebody's heart to get the rhythm back, that's a procedure.
Yes, I would be in charge of the procedure. The anesthesiologist would be in charge of the propofol part.
Okay. But, and so you divide the responsibility. One person's doing the procedure, the other one's doing the propofol.
That's correct.
But you don't really have anything to divide up when there's no procedure being done, do you?
I don't use propofol when there's no procedure being done.
Okay, because you've never practiced outside a hospital, have you?
I do practice outside of the hospital. I have outpatient clinic. I don't use propofol in the outpatient setting. And even in the inpatient setting, I pointed it out to you that I only have it used in the ICU or the procedure rooms.
Okay, so you're only using propofol when you're doing a procedure.
Yes, sir.
Okay. And I take it have you ever heard of propofol being used as a pre-med for surgery?
Sure. Yes.
They use it as a pre-med to sedate the patient, don't they?
In the inpatient setting, in the appropriate room, yes.
And when they use it as a pre-med, they use a lot less than they use in a procedure, don't they?
Depending on what they're premedicating the patient for. What do you mean by a lot less? I'm not sure I follow.
Okay, well, if we take it to numbers, when you're doing a procedure, hypothetically, you got a patient, Jackson size, 135 pounds, about 60 kilograms. How much propofol would you use?
I would leave it to the anesthesiologist, but what I know is it depends on a number of factors, not just the size of patient. Size of patient is a good starting point, but do we use it in combination with some other drugs? Sometimes propofol is not used by itself. It's sometimes used with other sedatives, such as, benzodiazepine. So if you use it with other sedatives, you can use a lower dose, 50 to 100 microgram per kilogram per minute. If you use it by itself and it is a primary agent, you can use it a little bit higher dose, 100, 150 microgram per kilogram per minute. And again, they have these small boluses, and they repeat these boluses every 10 seconds as they monitor up to the point that the anesthesiologist assessed and felt that we have achieved the desired effect. So,
I'm not sure I understood all that. Let me try and put it in a term that maybe I could understand. Would you use 1 milligram per kilogram of body weight as a starting point?
I think microgram per kilogram per minute. 50 to 100 microgram. Microgram is 10 to the minus 6. So you're talking about milligram. That's 10 to the minus 3. So it's 1,000 of a milligram.
Now, Dr. Cooper, who was here a little while ago, indicated that for procedural sedation, she would use 1 milligram per kilogram of body weight. Is that a term that you disagree with that?
It's not like I disagree or not. It depends on what procedure she's doing, what she's comfortable with. As I said, the recommended dose to start, 0.1, 0.15, if you use propofol in combination with some other drugs. Now, if you use it by itself, you may need a higher dose to achieve the desired effect.